administrators may.
I'll just a minute, sir. Sorry for the inconvenience, actually.
No problem. No problem. I think we are able to see now. We are able to see your screen now.
Yes, sir. Just a minute, sir.
You can start. You can start. So where you stopped last time.
Yes, sir. A very good morning to all. Sorry for the troubleshooting. So last time we had discussed about the recent guidelines of surviving sepsis campaign 2021. So today we will be reviewing the biomarkers in the sepsis. Last time we all already discussed some of the biomarkers in sepsis. What is the importance for identifying this biomarkers in the sepsis? We'll just have a small recap about that. The biomarkers should be highly sensitive and specific and should be able to diagnose the sepsis from the non-septic causes or the infectious from the non-infectious causes, and also should be validated for the prognostication and should be easily measurable as a point of care test and should have high sensitivity and specificity. They are usually basically studied nowadays in detail because up till now we were treating the sepsis in a conventional manner, detecting the bacteria through the normal culture growth and then treating the bacteria according to the culture resistivity and sensitivity reports. But nowadays we are being drawn towards the molecular biology and more dealing with the molecular basis of the sepsis. So let's see the new biomarkers. We already know the current ongoing traditional biomarkers, that is the C-reactive protein and the procalcitonin. The C-reactive protein being an acute phase protein and the procalcitonin is a hormokine. We know the normal values of them, and we know that the C-reactive protein is and the procalcitonin are being used for the prognostication of sepsis along with the other prognostication factors, and the procalcitonin being used for de-escalation of antibiotics and all. So let us now emphasize on the new biomarkers of the sepsis. So the sepsis basically has in the pathogenesis leading to the innate, affecting both the innate and the adaptive immunity in the human system. So basically, what are the newer innate response biomarkers? They are the PAMs and the DAMs, that is the pathological associated molecular patterns and the damage associated molecular patterns. So basically, they are the molecular warnings. They are circulating, which activate the innate immune response by mediating by reacting with the pattern recognition receptor on the host cells, and they basically activate the circulating T cells in the immune system. So basically, they are detected by the uh, mannose binding lecithin based PAMP blood assay, which detect these molecular pathogens on from the blood or any of the fluid from the specific organ site. And all we can target this PAMP removal through either the blood purification techniques or either some of the molecular biomarkers which are targeting this PAMP. And this has shown benefit in improving the hemodynamics and improving the mortality in the animal cells. So basically, the drug which is targeting the PAMP are the CAL02. So basically, it is a liposomal agent, and many of the gram-positive bacteria like the Streptococcus pneumoniae and the Streptococcus pyogen, they are secreting the liposomal enzymes like the pneumolysin and the streptolysin O, which are the endotoxin, which are specifically responsible for the sepsis endotoxemia. So if we are developing the artificial liposomes, then they can sequester these bacterial toxins and can henceforth lower the bacterial endotoxemia. So basically, CAL02, it's a novel antitoxin agent which is consisting of a mixture of liposome, and it is basically creating a large and stable lipid microdomain which is able to track this bacterial endotoxin. So its half-life is 8 hours, and it can rapidly reach the lung, and it does not impair the microcirculation. So basically, a very small trial was done on 19 patients in the patient who was suffering from the severe pneumococcal pneumonia. And the drug was intravenously administered for 2 days, and it was compared to the standard antibiotic therapy. And it showed that it reduced the organ dysfunction. And there was a rapid declining of the C-reactive and the procalcitonin with the CAL02 group. But since the data was not done on a larger population, we henceforth need more data, which is conducting a larger clinical trial to confirm this clinical value of CAL02. The next agent is calprotectin. So calprotectin is basically a calcium binding protein in the neutrophil cytosol, which is reacting to the bacterial infection, and it consists of two subunits, 108 and A9, and it increases within few hours of bacterial endotoxemia, and it is directly correlating with the 30-day mortality, and it has a confidence in with a confidence interval of 95% of 0.66 to 0.86. The area under curve was 0.77 compared to procalcitonin of 0.73. So it is basically just like procalcitonin can be used to differentiate the bacterial pneumonia from the viral pneumonia. And further studies are required for the same to incorporate the calprotectin in guiding the initiation and de-escalation of antibiotic therapy in the patient with septic shock, just like procalcitonin. So the second, we are dealing with the cytokine and chemokine biomarkers. So it is very well-known biomarker, that is interleukin-6, which was being very far used in SARS COVID-19 pneumonia. So for the sepsis, according to the sepsis 3, there was a study done to discriminate sepsis from controls. So it had a sensitivity of 80.4% and specificity of 88.9%. And when to diagnose septic shock from sepsis, it had a sensitivity of 76.1% and specificity of 78.4%. And the optimal cutoff value was almost similar to procalcitonin and pentaxin 3. But further studies are still needed to incorporate it in distinguishing the viral and the biological bacterial infections. The second molecule, which is almost similar to the interleukin 6, is a cytokine interleukin 7. And it is basically a pluripotent cytokine which is released by the bone marrow and the thymic stromal cells. And it is said to reverse the sepsis-induced lymphopenia and avoid excessive inflammatory response. And it is harboring the anti-apoptotic properties, induces the pro-inflammatory native and memory T cells, and it is restoring the functional capacity of the exhausted C cells, and it is said to reverse the sepsis-induced depression of interferon gamma. So a newer molecule, which is a recombinant interleukin 7, in a glycosylated form, is being under clinical trial. It is CYT107. So basically, it is said to improve the immune function with increase in the T cell lymphocyte proliferation, and it enhances the lymphocyte survival. So recently a phase 2 trial is going on the patient who are vasopressor dependent septic shock. They are being given this intramuscular injections of low doses and high doses injections of CYT107. And it is said that there is a 3.5 to 4.5 fold increase in the absolute lymphocyte count and in circulating CD4 and CD8 T cells. And they are said to be persistent for at least 4 weeks after the drug administration. So, and there is no much side effects with the with the CYT107. It is leading to some injection site reaction. So current investigations are going on how to prevent such um, injection site reaction and incorporate this interleukin 7 into clinical practice. The second molecule is the monocyte chemotretin protein 1. It is basically inducing oxidative stress, and it is being secreted by the monocytes and the endothelial cells, and it is leading to this inflammatory cascade. And it is correlating with the sepsis severity along with the other factors like the tumor necrosis factor alpha, interleukin 6, interleukin 8, and interleukin 10. Coming to the next molecule is a pentraxin 3. It is playing a role in the early phase inflammation by activating the classical complement pathway and by facilitating the pathogen recognition by the macrophages and the dendritic cells. And the prospective study is being going on 101 patients, which is comparing the pentraxin 3, the monocyte chemotretin protein 1, and the angiopoietin 2 levels on the first day of sepsis. And it is said that all the three biomarkers were being increased in the patients with sepsis. So the further studies are going on to incorporate the pentraxin 3. Then coming to the newer molecule, that is a tumor necrosis factor. So basically, it is the tumor necrosis factors. There are two membrane-bound receptors, the TNF-R1 and the TNF-R2, which are being released in the circulation, and we can actually detect the cleavage molecules of this receptor. That is a soluble molecule as TNF-R1 and soluble TNF-R2 in the blood that retains its ability to bind to the tumor necrosis factor and inhibits its acute activity. So it is also being used to categorize the disorder along with the factors like interleukin 1, tumor necrosis factor, interleukin 6, and interleukin 10. And current studies are going on to study this marker also. Then coming to the soluble urokinase type plasminogen activating receptor, that is the SUPAR, and its concentration is directly correlating with the immune system activity, including the cell adhesion, the migration, the chemostasis process, the immune activation, the tissue remodeling, invasion, and signal transduction. And it has a moderate diagnostic value for the bacterial infection or the systemic inflammation with an India under curve of 0.82. And when it was studied in the sepsis, it has a sensitivity of 0.76 and a specificity of 0.78. And for the SARS, its sensitivity was 0.81 and specificity of 0.86. Coming to the other molecule, that is presepsin, it is basically a soluble CD14 biomarker, which is related to the bacterial phagocytosis and the liposomal cleavage. And it is used for the initial diagnosis and sepsis risk stratification, but there are still insufficient evidence. So further studies need to be ongoing. Then coming to the CD64, it is basically a high affinity immunoglobulin Fc gamma receptor expressed on the monocytes, eosinophils, and neutrophils. And it also rises within few hours of endotoxemia. And in 2019, there was a meta-analysis of 14 study conducted in 2,400 patients. where it was compared with the CRP and PCT. So the receptor operator curve uh, versus CRP was almost 0.84, and for the PCT it was 0.84, almost similar. So basically CD4 is almost accountable along with the CRP and PCT, but its use in the clinical practice is very challenging due to its measuring being done through the flow cytometry. So nowadays, a newer smartphone-based technique of this measuring CD4 by the microfluidic biochip is being undergoing on, and let's see how much benefit is going to do. Then comes this TREM, there is a soluble triggering receptor being expressed on the myeloid cells. It is being S-TREM receptor is being expressed on the surface of the polymorphonuclear cells and mature lymphocytes, and it's upregulated by the bacterial lipopolysaccharide. So basically, in 2022, study was done which shows its sensitivity and specificity of 0.82 to 0.81. So it is said that it was very significantly high level studied in the non-survivors when compared to the survivors, but it failed to have any value in the culture negative septic patients. And the study was done correlating this STREM1 with the CRP and interleukin 6. And STREM1 did outperform PCT in diagnosing the severe sepsis. So one of the molecule which is targeting this host immune response of STREM and is a nangibotide, which is a synthetic TREM1 antagonist peptide that inhibits the activation of the TREM1 receptors. So basically, it decreases the leukocyte activation and innate immune response, and also has a protective cardiovascular system effect in the sepsis patient. So basically, two studies were done. One was MOT-C 104 study, which was done in healthy volunteers to assess the safety, tolerability, and pharmacokinetic in the healthy volunteers. And nangibotide, it was very safely tolerated in this patient, even at highest dose of 5 milligram per kg bolus, followed by 6 milligram per kg per hour continuous infusion over 7.75 hours. And there was no drug-related adverse effect and no anti-drug antibodies being detected after this administration. And a study is going on that is MOTC 201. It is being done in the septic shock patients. It's a multi-center randomized control trial. And there is a continuous infusion of nangibotide given at 0.31 and 3 milligram per kg per hour after an bolus loading dose of 5 milligram per kg. And it's being compared to the placebo. And there is no, again, it is being said to reduce the organ dysfunction, the ICU length of stay, and the organ support requirement as compared to placebo in the patient with the septic shock. And there was a decrease in the SOFA score also from the baseline to day 7 on the patients were treated with the nangibotide. Then coming to the toll-like receptor 4, it's being the receptors are being involved in the induction of the inflammatory genes, and the toll-like 4 receptor is being found. It can recognize the lipopolysaccharide molecules at this cell surfaces as compared to the other toll-like receptors like 3, 7, 8, and 9, which are exclusively expressed on the endosomal compartments of and can recognize the viral components. So TLR4, along with the other biomarkers like PCT and CRP, TLR2 and TLR4 expression is to determine the severity of sepsis, the prevalence in severity of sepsis are diagnostic biomarkers. And TLR4 signaling inflammation pathway was also being recognized in the COVID-19 virus also. Then coming to the program DEATH1 receptor, the PD1 receptor, it's a negative regulatory molecule highly expressed on the activated T cells and B cells And there are two ligands which are specific for the PD-1, that is a PDL1 and PDL2, which are said to downregulate the T cell activation upon binding to the PD-1 receptors. And these are basically the immune checkpoint inhibitors. And the PD-1 activation is said to downregulate the T cell activation, which alter the balance between the immune tolerance and the immune mediated organ damage. So the recent prospective observational cohort studies going on, uh, which study the degree of the NK cell proliferation in four signaling molecular pathway PD1, CD8, PDL1, and CD86, which is directly correlating with the SOFA score. And they were found to have an independent risk factor for the 28-day mortality. When compared to the SOFA score, their combination area under curve was 0.65 with the PDL1, 0.72 with the SOFA score, and 0.80 with the NK cell expression. So the area under curve of this combination model was most predictive, and further studies are still needed to take this PD1 as a novel prognostic marker for mortality in sepsis. So an antibody is developed against this programmed cell death protein 1 and programmed cell death ligand 1. It is nivolumab. It is a fully human monoclonal antibody, which is a CD28 family antibody, and it inhibits the PD1 PDL1 interaction, resulting in enhanced interferon gamma production, and it promotes the immune response and antigen specific T cell responses. It is said to decrease the apoptosis and improve the immune T cell function and restore the neutrophil and monocyte functions in the patient with septic shock. So a phase 1 randomized control trial was done by Hodgkins et al. Showed that the PD1 and PDL1 pathway inhibition was very safe with the sepsis induced immunosuppression after high dose of nivolumab of 300 to 900 milligram. And the MLHA DR1 expression was maintained high until day 38. But there was no evidence of increase in the absolute lymphocyte count or cytokine level in the nivolumab group. And recently, a phase 1 and 2 trials have been conducted with a single dose of intravenous nivolumab in patient with vasopressor dependent sepsis. And it is said to improve the absolute lymphocyte counts and MLHA-DR expression. And the combination immune therapy associating with the nivolumab and interferon gamma are being considered as a rescue therapy in the refractory fungal infection, but its clinical values still remain to be confirmed. Now, already we have discussed the molecular markers, the cytokines. Now, the microcirculation related biomarkers, which are the angiopoietin 1 and angiopoietin 2. So basically, the angiopoietin system helps to control the vascular endothelial cell responses, and these vascular endothelial responses are responsible for the fluid losses in the septic patients. So high levels of this angiotensin 2 and low level of angiotensin 1 with high level of angiotensin 2 to angiotensin 1 ratio has been associated with a poor clinical outcome, organ dysfunction, and adverse outcome in the patient with sepsis. And they are predicting the severity in the patient with ARDS also. So small studies utilizing the sepsis 3 criteria was being done in the patient with sepsis and septic shock. So it demonstrated that there was an elevated level of angiotensin 2 along with the levels of monocyte chemotrectin protein 1 and pentraxin 3. And there was low level of angiotensin 1 in the patients with sepsis with an area under curve of 0.63. So angiotensin 2 is basically directly relating to the fibrinolysis and the coagulation pathways in the patient with sepsis shock. And maybe it can be utilized as a newer biomarker in prognostication of septic shock. Celeprezin is basically a newer vasopressin. It's a selective V1A versus V2 receptor agonist, and it can help prevent the microvascular leakage and is associated with a positive fluid balance when it was studied in the bovine models of sepsis. So, in the experimental model, it is said to increase and stabilize the mean arterial pressure, and in a recent and hence increase the survival rate. In a recent randomized phase 2A control trial, it was administered in 53 patients with the early septic shock, and it is said to reduce the doses of norepinephrine and appear to diminish the fluid balance and shorten the duration of the mechanical ventilation. But it does not differ significantly in the ventilator or the vasopressin free days. And in the first 6 hours, it is said to significantly increase the level of the mean arterial pressure and lower the level of the norepinephrine. A study was done, that is a sepsis act, where celebration was given in the patient with septic shock. And we can see that the outcomes on the ventilator and vasopressor free days with celebration was 15, with a confidence interval of 95%, as compared to the placebo of 14.5. 90-day mortality was 40.6%. The RRT free days was almost equal, 18.5, and the ICO free days was 12.5. Then coming to a new marker, that is the andromodulin and proandromodulin. The adrenomodulin, it is a 52 amino acid peptide which is produced in the endothelial cell and the vascular smooth muscle cells, and it is basically mediating the vasodilation and helps in the systemic circulation. But this circulating ADM is very quickly degraded and being cleared off from the blood. So it is very difficult to detect this adrenomedulin level directly. But the middle molecule of this adrenomedulin, which is a proadrenomedulin, can be detected by the immunoassay. And it is said that this circulating proadrenomedulin level um, is responsible for can be cleared off from the blood easily. So a newer drug which is targeting this endothelial peptide is adrecizumab. It is a recombinant monoclonal anti-adrenomedulin antibody that protects the endogenous adrenomedulin from the proteolytic decay and increases its plasma half-life in a dose-dependent manner. And its mechanism basically relies on modulation of ADM equilibrium between the blood compartment and the interstitium. So basically, adrecizumab is restricted to the blood compartment, whereas the ADM freely diffuses across the endothelium in the extravascular space. And there is a shift of this ADM from the interstitium to the circulation. And this ADM will bind to the adrecizumab, and hence adrecizumab will reduce the ADM-mediated vasodilation, and it can increase and prolong the plasma concentration, and it can further increase the endothelial stabilization also. So it is said to have a excellent safety profile when it was conducted in a phase 1 human studies in the absence of systemic inflammation. Phase 2 randomized control trial to investigate its safety, tolerability, and efficacy is going on, and we have seen that we achieved an elevated ADM level of more than 70 picogram per ml, and an ENDRIOS 2 trial, which is enrolling a 300 patient, been randomized to give adrecizumab 2 and 4 milligram per kg versus placebo, is being recently completed, and let's see how we are able to incorporate this adrecizumab and further prevent the endothelial damages which are going on in the patient with sepsis. Another marker of organ dysfunction in sepsis are the microRNAs and the long non-coding RNAs. The microRNAs, they are basically post-transcriptionally regulating 60% of protein coding genes, and they are being regulating the proteins which are involved in the innate and the adaptive immune pathways. And the microRNA is characterized by the different host pathogen interactions, and more than 50 bacterial and viral infections are being studied for this characteristic of the polymorphisms which are being going on in the microRNA genes, and they are varying on from the person to person, and henceforth leading to so much variability in the infection susceptibility. Some person being having a long term duration of the sepsis, and some term having a very short duration. So this variations in the microRNA are being studied in the patient for sepsis. The another molecules are the long non-coding RNAs, which are a class of non-coding RNAs and transcripting for about 200 nucleotides. And they are being also responsible for these inflammatory mechanisms, which are ongoing on in the patients of sepsis. So basically, an Inc. multi prospective cohort study is being going on 120 patients, which is diagnosed sepsis. So from the long by studying the long non-coding RNAs, the it was being used with an to diagnose sepsis with an area under curve of 0.9, and then predictive 28-day mortality with an area under curve of 0.8, which was better than the Apache score, which an area under curve of 0.86, and lactate levels with an area under curve of 0.86. But still further studies are being needed to evaluate its role in the patient with sepsis. The another molecule is the matrix metalloproteases, and the tissue inhibiting metalloproteases like MMP2, MMP9, TIMP1, and TIMP2. They are being responsible for the regulation of the wound healing after the internal injury, and these are also being studied in the as a molecular marker for sepsis. So basically, we needed to study all these molecular markers of sepsis, because once we are incorporating the bacterial insult, it will trigger the markers like PAMs, DAMs, then again the cytokines, the interleukin 6 and interleukin 7. So these biomarkers are being studied, and we are being able to develop the antagonistic molecules against such biomarkers, and see how much response it is leading at the cellular level to prevent the further deterioration from the sepsis or septic shock. Sorry. So this is a small table where we are being studying the antibodies against these virulent factors. So let us study this antibacterial antibodies in details. So bacteria like Pseudomonas aeruginosa and Streptococcus aureus, they are being primarily responsible for this nosocomial infections. And today, up till today, we were being very conventionally treating with them with the antibiotics. But nowadays, there are newer developing antibodies which are being targeting the virulent factors of these positive bacteria. So the monoclonal antibodies, they are being targeting this molecular pathogens, like already in the Clostridium difficile, the monoclonal antibody like Bezlotoxumab has been FDA approved for as a single treatment for Clostridium difficile. So anti-Streptococcal aureus antibody, it's a Suvratoxumab. It is a human immunoglobulin G1 kappa monoclonal antibody with extended half-life that binds to the aflatoxin, and it has been effectively blocking this alpha toxin induced pore formation in the target cell membrane. So phase 1 trial is being going on with a single dose of 225, 750 to 5,000 milligram, which is being going on to evaluate the safety, tolerability, and the pharmacokinetics in 333 healthy patients. But no adverse effect has been encountered up till now. And a phase 2 trial is being conducted in the mechanically ventilated patients who are colonized with this Staph aureus susceptible or resistant methicillin, resistance to this methicillin, and a single intravenous dose of suvaroximab is being given against the placebo group, and it has said to be acceptable safety response. So the terminal half-life of this drug was approximate to be 70.1 to 84.6 days. The another molecule which is being developed, that is an AR301, salvacin monoclonal antibody, which is an immunoglobulin G1 monoclonal antibody. And it is also targeting this alpha toxins and neutralizing this alpha toxin receptors and preventing further uh, uh, oligomerization of these toxins. So a phase 2 trial is also going on in the patients with Staph aureus, hospital acquired, ventilator acquired, and community acquired, where the doses of salvacin is being administered as 1, 3, 10, and 20 milligram per kg. And it is said to shorter the duration of ventilation uh, up to 16.8 plus or minus 8.4 days in a placebo group versus 9.5 plus or minus 7.6 days in the treatment group. So there is a faster resolution of pneumonia being seen in this group. But since it is a very being conducted in a very small group, further studies are still needed to incorporate this salvacin into the clinical practice. So these were the two antibodies which were directing against the Staph aureus. Now coming to the antibody which is directed against the Pseudomonas aeruginosa, that is the Medi 3902. It's a bivalent bispecific human immunoglobulin G1 kappa monoclonal antibody that selectively binds to the protein and the PS1 exopolysaccharides on the surface of the Pseudomonas aeruginosa. And its mechanism is preventing the type 3 secretion, uh, injectisome mediated cytotoxicity and damage to the host cells. It mediates the phagocytic killing of the Pseudomonas aeruginosa on the host effector cells and inhibiting the bacterial attachment to the host epithelial cells. So a phase 1 single center first time human RCT was conducted, and single doses of 250, 750, 1500 and 3000 milligram compared to the placebo were given in 56 patients. And it is said to lower down the mechanical ventilation days in such patients. Now, another drug which is targeting the coagulation system is being developed, that is thrombomodulin ART 123, and it's a recombinant human thrombomodulin, which is a glycoprotein with an approximate molecular weight of 64,000 Dalton, and it is said to exhibit both the anticoagulation and anti-inflammatory effect, and it is said to improve the DIC parameters and exhibit the inhibitory effects on the pro-inflammatory cytokines also. So a phase 1 trial was conducted on 12 healthy volunteers, and the terminal half-life of this drug was determined to be 25 to 28 hours when intravenously injected as a bolus dose, and it was cleared by the kidney. And a phase 2B trial is being conducted in 371 patients of septic shock with suspected DIC, and there is no significant reduced mortality when compared to placebo. And a phase 3 trial is being conducted to confirm the efficacy and safety with a 0.06 milligram per kg in a patient with severe sepsis and septic and coagulopathy. So there was no actually 28-day all mortality significant difference when compared to placebo, but the absolute risk reduction of death was 2.55%. And currently this ART 123 has been shown to be having a safe effective dose being utilized by Japan as recomodulin. In Japan, it is available as recomodulin. They're using it for the septic associated coagulopathy. Coming to the another molecule, which is targeting the end organ damage, especially the renal dysfunction in the patient with sepsis. It's an alkaline phosphatase. It's an endogenous enzyme exerting detoxifying effect, protecting against the renal inflammation. And in the first clinic trial, it was shown to improve the renal function in the patient with septic shock. And how can we forget the stem cells? It is the CX611. They are intravenously administered product of the allogenic adipose-derived stem cells in the patients who are developing sepsis and early rheumatoid arthritis. Again, we know that the stem cells are basically the potent regulator of the immune system. It inhibit the T cell activation and B cell functions and responsible for the dendritic cells maturation. So again, it is being going on as a phase 1 trial, healthy trial, to assess the safety, tolerability, and effect of this stem cells. And 3 different doses of stem cells were being given. However, the vital signs and symptoms were not influenced by the stem cells, except some febrile response was being noticed. But the laboratory measurement revealed that there was an increased pro-inflammatory interleukin 6, interleukin 8, anti-inflammatory molecules like interleukin 10 and tumor growth factor beta were increased in this patient when compared to placebo. And a phase 2b/2a trial to assess the safety of the stem cells were conducted in a patient with community acquired pneumonia. And maybe there can we can study these stem cells to have better effects on the pro and the inflammatory cytokines, but a large clinical trials need to be done for this studying the stem cells. So basically, these are small summary tables given for the various biomarkers, their ability to predict sepsis, to diagnose or either differentiate SARS from sepsis or septic shock. I'm not going on in, we already discussed all these biomarkers. This is just a small, these are just small tables which are showing these biomarkers in predicting the mortality, the diagnosis, and their comparison to the other biomarkers and their area under curve. Now, after studying all these biomarkers, the antibodies, the newer vasopressin analog like salipressin and all, the last topic to be discussed is the blood purification therapies in the patient with septic shock. So the blood purification therapies in the patient with septic shock is a promising approach, which is said to remove the inflammatory mediators like the PAMs or cytokines. And basically, several theories have been proposed for this blood purification technique therapies. One is a cytokine peak hypothesis, which said that the blood purification can decrease the pro-inflammatory and the anti-inflammatory mediator concentration during the early sepsis and avoid attaining a toxic threshold and thus limiting the local deleterious effect of the cytokines and henceforth reducing the organ dysfunction. Later, a hypothesis like the threshold immune modulation hypothesis, which suggests that cytokine removal from the blood can mobilize the cytokines from the tissue and they can further reduce their local deleterious effects. Now, the recent model being studied is a cytokinetic model, which says that we can store the concentration gradient, the leukocyte hemostasis being driven towards the tissue with the higher cytokine levels. And with the help of this blood purification technique, we can lower the cytokine blood concentration. So the blood purification therapy, which basically targets on removing the pathogen from the blood, removing the endotoxin or the PAMP-like molecules from the blood, removing the activated leukocytes or reprogramming leukocytes from the blood, and reducing the cytokine blood levels, and henceforth reducing the damage to the host immune system. So the techniques which are being studied for removing the endotoxin is this. We have developed called polymyxin B or toramyxin. It is one of the most widely used endotoxin removal therapies. Toramyxin first developed by Toray company from Tokyo, Japan. It is an removal therapy by adsorption of the molecules with help of the polymyxin B immunomobilized fiber column, and it is being routinely used in Japan for the patients with the gram-negative bacterial infection. And numerous randomized control trials have been done with this toramyxin in a patient with severe septic shock with endotoxin activity levels and endotoxin assays between zero point 0.6 to zero point 0.9. There are being trials like the UFAS trial, the Abdomix trial, and the Euphrates trial being going on. The UFAS trial was conducted in 2009 in a 64 septic shock patients, and the conventional therapy versus 2 sessions of the polymyxin B hemoperfusion was conducted, and it said that there was they were able to achieve high mean arterial pressure, lower the pressure requires, higher PO to FiO2 ratio was achieved, and lower, so it was said to lower the SOFA score and lower the 28-day mortality score. But there was no clinical difference on the length of ICU stay. So basically, this UFAS trial was conducted on a very small group of only 64 patients. Then in 2015, PNATL conducted an Abdomix trial. It was use of this hemoperfusion with polymyxin B in the patient with peritonitis with septic shock. It was conducted in basically 232 patients, and there was again no difference in the 28 and 90-day mortality, and no difference in the reduction of the SOFA score when studied from day 0 to day 28, and no difference in the cytokine levels also, and no impact on the hemodynamics also. Then a Euphrates trial was conducted by Dellinger in 2018. Here we studied 450 septic shock patients with endotoxin activity level of 0.6 or higher, and conventional therapy versus plus the 2 sessions of polymyxin B hemoperfusion versus the conventional therapy was studied, and there was again no difference in the 28-day mortality, and there was a higher hemo uh, or the ventilatory free days assay. But this polymyxin B or toremyxin is being routinely used in Japan in the patient with gram-negative bacteria. Then coming to the lipopolysaccharide absorber, the Elteco, a company from Elteco Medical from Sweden, has developed this Elteco LPS adsorber, and it contains a synthetic peptide developed from the endotoxin for this endotoxin adsorption, and it's basically a porous polyethylene matrix. And an asset multicentral trial was conducted, but it was terminated early because of the patient recruitment issues. Then for the removal of the cytokines, we have developed a high volume hemofiltration technique. So CRRT with high filtration rate of more than 50 molecules, and Ivory randomized control trial failed to find any significance in the mortality between the high volume group versus the standard 35 ml per kg volume group, and there was no any improvement in the hemodynamic parameters or the severity scores and the length of scores. And again, there are drawbacks of this high flow, high volume hemofiltration, like loss of small active molecules like nutrients, vitamins, and the trace elements. So uh, cascade hemofiltration was extracorporeal circuit, allowing exclusive removal of only middle molecular weights. But any human studies has failed to find any beneficial effect of this cascade hemofiltration also. Then coming to the high cutoff membrane, high cutoff membrane is being said to design for the middle molecular weight pathogen removal only. So it can, when applied with the conventional convective therapy, it can remove the pro and anti-inflammatory mediators with a high cost of massive albumin leakage. Up to 15 gram albumin loss was noted in 4 hours. So modified high cutoff membrane were developed. They were being based on the diffusive rather than convective therapy with acceptable albumin losses. And recent studies suggest that it can result in high ICU mortality benefits. They can decrease the ICU length of stay and vasopressor days, and they are said to attenuate the inflammatory markers like tumor necrosis factor alpha and some interleukins when compared to the normal CVH. However, a recent control trial was done in the patient with AKI, and it did not show any mortality benefit or any vasopressor changes. Then coming to the coupled plasma filtration adsorption technique, it is basically a blood purification technology in which the plasma is extracted from the blood by a high cutoff filter at the start of the extracorporeal circuits, and it is run through the sorbent cartridge where the pro and inflammatory mediators and endotoxins are being absorbed. So compact 1 and compact 2 trials are being going on. In the compact 1 trial, it was incorporated in 192 patients where the CPFA was studied against the standard care, and but it had high concerns regarding the inadequate dosage, the clotting risk, and the cost effectiveness. So beneficial mortality rate was observed receiving the high dose of CPFA. In the compact 2 trial, it was to assess the consequences of the higher doses, and on combining the plasma filtration and adsorption filtration. But unfortunately, it was terminated earlier, so we cannot derive the data. Then coming to the cytosol therapy. The cytosol therapy is being, it's a hemoperfusion cartridge to absorb the high cytokines. And it is said to remove the broad spectrum cytokines, complement growth factors, myoglobins, bilirubin, bile acids, PAMs, DAMs, with a removal rate of almost more than 90%, 90 to 95% at 120 minutes. And there are higher evidence of favorable outcome on the hemodynamic parameters and blood lactate levels, but no decline in the SOFA score. But interleukin 6 levels have said to be lower on by the cytosol. But again, the cytosol cost around a lakh in India. Then coming to the HA330 and HA380, it is also being developed. It is being developed from by company from China. It's a high volume resin hemoperfusion cartridge, and was studying the patient with cytokine storm, and clinical benefits were in reducing the inflammatory mediators, mortality, ICU length of stay. But here it is said that in the patient with when used with AKI, there was no improvement in the prognosis, and also the resin which we are using here needs a heparin and acidic environment for its functioning. The oxyrich, it's basically an AN69 copolymer based membrane, which is being responsible for this cytotoxin and cytokine and endotoxin removal. It's basically has a 3-layer. First layer, which is ANA69, which is responsible for the adsorption of the cytokine and removal of the solutes by the conventional. The second layer was for the removal of the endotoxin, and the third layer, which is an heparin grafted, it is said to reduce the local thrombogenicity. So it is said to have benefited in the hemodynamic effect, which being reflected by the SOFA score and the vasopressor dose reduction. And it is said to stabilize the hemodynamic parameters and improve the organ dysfunction also. But there are and high performance in the adsorption ability for the endotoxins and inflammatory markers. So these are some of the studies which are comparing this CRRT oxyrich in the patients with septic shock with AKI, and they have shown benefited results in SOFA score. Some shows to have benefit in urine output and MAP level. And recent study by Prato in 2017 has also shown to reduce the PCT and CRP levels. Then the another technique is the Serif 100 microbiome affinity blood filter. It is also said to have an endothelial, the bacterial vascular cells are said to have heparin sulfate as a receptor for invasion on the human cells. So basically this hemoperfusion cartridge bind to this heparin sulfate negatively charged molecules, and said to These heparinized beads are being able to bind to these various pathogens like viruses like Zika virus, cytomegalovirus, adenovirus, the gram-positive and gram-negative bacteria, and positively charged cytokines. So very small study is being conducted in Germany on only 15 patients with septic shock requiring RRT, and no adverse effect was seen. But this is a very small study, so we don't know how much efficacious this Seraph 100 microbiome affinity blood filter is. Then the granite hemofilter. It's basically a hemofilter containing hollow polysulfone fibers, which are coated with the mannose binding lectin, and it's remove the pathogen from the blood infected pathogens from the infected patients. So it's basically mechanism is that bacteria and viruses have mannose binding lectin or Fc portion of human immunoglobulin. It is being bind on this polysulfone filters of this granite hemofilter, and by the process of opsonization, it is able to remove this pathogen associated molecules from the blood and henceforth decrease the cytokine storm. Then coming to the hemopurifier, it is basically consisting of plasma filter with a pore size of 200 nanomole, and when the blood passes through this plasma filter with a pressure gradient allows the plasma viruses and soluble glycopeptides to bind to this filaments, and hence are removed by this hemopurifier. And it was proposed to for the treatment of the viral infections, but it was used along with the hemodialysis 3 times per week in end-stage renal disease in patients with hepatitis C virus infection. And combination therapy have said to decrease the hepatitis C viral load by 57% in 1 week. And it was also being once tried for the Ebola virus and MERS-CoV virus. So ending up this blood purification techniques. So basically, to choose this blood purification techniques, we need to find out whether the patient is having AKI, ELI, or without AKI, and hence determine what type of blood purification technique should be used. If the patient with AKI is having ongoing oliguria, fluid overload, metabolic acidosis, hyperkalemia, serum creatinine on higher side, then if we want to go with the blood purification techniques, we can go with the renal replacement CVVHD or CVV hemodiafiltration technique. And if there is no ongoing kidney injury, and even with ongoing kidney injury, to determine whether to go with oxyris or cytosorb, but determining on the ondotoxin levels or the interleukin levels. So that's all for the blood purification techniques. So I would hereby like to conclude my topic of today, which was based on the sepsis new biomarkers, the newer advances which are going on in the sepsis, and the newer blood purification techniques which are going on in the sepsis. Thank you.
Thank you, Dr. Urvi. I think it was a very, very informative, exhaustive, and comprehensive description, not necessarily what the Surviving Sepsis campaign has recommended, but a comprehensive review of where we are headed, what is in future, what we can expect in terms of diagnosis and um, probably interventional therapy for patients with sepsis, especially those who are appearing for the ongoing upcoming DRNB exit exams, DM exit exams. I think this is an excellent talk. A couple of these 2 lectures, I think you need not go back to any resource again to read about what is what you're likely to be asked in the exam, because biomarkers in sepsis and extracorporeal techniques in sepsis are essay questions in both the DRNB exit as well as the DM exit exam. So it's an excellent review. Thank you, Dr. Urbi. So
Thank you.
next week, we will have a similar review of the current guidelines in the management of acute heart failure, especially in the context of newer recognition of cardiac power output and the availability of extracorporeal devices in heart failure that we will deal with next week. Thank you very much, all of you. Join us again next week. Any queries on this topic, please do post on the group in which you got this link. We will be able to get the queries and we will answer them individually. Thank you very much. Have a good day. Bye bye.
Sir, for giving me this opportunity.
Thank you. Bye bye.
Goodbye, sir.